This conference will now be recorded.
Good evening, everyone. This is Rick Davis for the High Risk, Recurrent and Advanced Prostate Cancer Group on December the 5th. We've got a full house, 40 people. Just a word of thanks to our sponsors, Bayer, Pfizer, Foundation Medicine, Janssen. I think I'm missing somebody. I should write them down.
Novartis?
I'm sorry?
Novartis?
Not yet,
Oh,
but
not
it's
yet.
in the pipeline.
Okay.
we got a couple of people that are out for signature, as they say, and once they've signed, then we'll name them. If they sign and they haven't paid us, we do name them. Okay, so we got at least one name in there where we're waiting for the bucks, but we've signed the agreement, so that's okay. So they're good. I will say this year there's been a lot of interest, and that's obviously a good thing. One thing that I've noticed, because of certain things that have happened, and you might have read about some of these things in the reminder this week. If you didn't read the reminder, it's probably worth it. I'm more and more convinced that AnCan is really the main and major patient voice in terms of prostate cancer. We may not be the largest, and we may not have the largest distribution. In fact, our distribution is just a fraction of the 0us2. But we have more dialogue with the patients than anybody else. And therefore, we are so much closer to anybody, to the patients, and able to voice the patient's voice. And I mean, it just struck me this week when the Society for Nuclear Medicine told me that they had representatives from 2 other major organizations on their prostate cancer task force, and nobody has said anything about experience badging. And it took us to call for that meeting. So given that we have nobody new, we'll jump right in. And since Peter's got to make a move fairly soon, Peter, let's start with you, sir.
Okay. When I think the last time I reported in, most of you know I'm on Keytruda infusions. I just had my number 4 infusion about a little over a week and a half ago. And I think I told you that we started it up again when I got back to Maui, because we had pulled the plug in Minnesota because my PSA was going up, doubling, and it had gone up to 7.5 or 7.4 or something. And then I got back to Maui, I did a blood test, and lo and behold, it dropped about 75% down from 7.4 to 2.4. In consultation with Antanarakis in Minnesota and my local doc here, Okazaki, and Dr. Schultz, we said, let's get going again. So I did number 4. And I did a blood test just before that, and amazingly enough, my PSA dropped another point before my last infusion. So it's down to 1.3 or 1.4. I'll do another blood test Monday, a week from today, before my next infusion on a week from tomorrow. And I'll know more then. I have to admit, even though I don't think I'm going through any side effects, I've got some side effects, anxiety. And I'm not sure what to do about this. I mean, I'm very optimistic and very positive about getting a substantial remission from this treatment. But at the same time, I'm dealing with anxiety about side effects. And the more I read about side effects, the from Keytruda, the more anxiety I get. So, you know, it talks about muscle pain and skeletal pain and this and that. And I start to think, oh no, did I just throw my back out, or am I feeling a side effect? You know, anyway, just weird stuff going through my head. It reminds me of back in the early days when I had anxiety of PSA, you know, before my surgery or right after my surgery. Anyway, so that's one thing. The other thing is, I think I mentioned the last time that and I sent a paper recently to by the Antanarachis from a talk he gave to Rick and Len and Herb and several others. And I know oncologists now, as standard of care, are pushing people to get germline and beyond screening. But I think in my situation, it wouldn't have been wonderful if urologists did this. Would it be? I mean, even one person like myself who falls in the sweet spot. I mean, if it's, you know, my mind says, you know, if it was possible, I could have avoided radiation, 2 kinds of radiation. I could have avoided maybe even surgery. I could have avoided chemotherapy. However, the way Keytruda is written is, you know, you're supposed to do it almost as a last resort. But I know there are studies going on that with colorectal cancer that show that people with no treatment are starting to show remission. So it makes me think that you know, maybe we need to reevaluate things, and maybe urologists need to get on board and see that genetic testing is imperative, even if it's rare people like me. It's worth it. So that's all I have to say.
Peter, that's a very good point. And, you know, we took a survey, the active surveillance people with Howard, and we asked the questions about genetic testing. And urologists aren't doing it enough.
Right.
And
Yeah.
I think that's one of the things I'd like to bring up to the urologists when we present this data, that in fact, this needs to be part of the spectrum of tests for everybody. Even if you're a 3+3, you don't know.
So
Right.
that is being addressed. The new early guidelines were circulated last week, and there's a number of us at AnCan that are reviewing those early guidelines. And one of the guidelines, I forget which one, and I'd have to go back and look, but they are being recommended to test not everybody, but certain people where they see that there's a high risk. If there's a family history, African Americans, Ashkenazi Jews, but it's not everybody. But the point is that this genetic testing, at least at a germline level, is definitely on the radar of the AUA, and they are working now to start encouraging. I mean, I think that for somebody like Peter, we're really talking a different situation. I don't see that somatic testing will necessarily become a run-of-the-mill test unless there's a reason to do it. So if somebody like Peter comes back with MSH6, which is or is it MSH or MSL6? I forget, MSH6, right?
H. Yep.
Right. So if somebody like Peter comes back with MSH6, which is a Lynch syndrome, then maybe there is a reason, even at that early stage, to follow up with a somatic test. But I don't see them just doing a somatic test per se. What do you say about that, Peter?
I think that's legitimate, but I think urologists and even general practitioners probably should get on the bandwagon for germline testing. I think it's the future, and the future is here. I mean, it's so cheap and easy to do that to me it's a no-brainer. It should be done.
So I'll tell you a little. It's funny you raised this today because we're in conversation with Myriad, and I invited them if they wanted to attend tonight. Told them they were very welcome, and they've offered us second time around. They've offered us some significant funding. Back in May or June, they turned us down because we told them that we do not do branded presentations. And they said, well, if you don't do branded presentations, then you're not for us. And we said, fine. And then they called us in November and they said, we'd like to talk to you again. And we had a meeting and we gave them a proposal, and they came back to me this morning. And one of the things they said was, we'd like to attend all of your meetings for 1 or 2 times, and we'd like to make a presentation about genetic and genomic testing, because our research says that most prostate men don't know about it. So I wrote back to them. I said, you don't know our guys. You don't know our group. I said, believe me, we talk about genetic and genomic testing in most of our groups. I said in the advanced group, probably 75, and the low intermediate group, probably 75% of the meetings, we will discuss it in detail, and we ask every new man whether they've been tested. I said in the active surveillance group, probably 50% of the time we're talking about testing. So I said, you're very welcome to come in, but if you want to make a presentation non-branded, you can do it as a seminar before we start one time, but we don't need myriad people talking to us about germline and somatic testing. Of course, the other big problem with Myriad's germline testing is it's hard for us to recommend Myriad as a name when we can send somebody to Promise and they get it for free. And there's not a lot. Now, one thing that's real interesting with Myriad is that they are going to be offering, or they are just about to introduce, a somatic test that will compete with Tempus and Foundation Medicine and others. So I'm sure we'll work something out with them. Anyway, I just thought I'd mention that to you because it's so ironic. We talk about it every time, and I hope they listen so they'll hear about this discussion we're having. Anybody have anything else they'd like to say to Peter?
It's John. Actually a couple questions for you, Peter. One is how do you make sense of that sharp increase and then delayed drop in your PSA? Is that somehow characteristic of the drug, of the Keytruda?
Schultz is the one that picked up on it first for me, and Len might be able to describe it better. I don't understand the biology, but Schultz said, don't write off. When I told him we were pulling the plug, he said, well, don't write this off. It could be, that the cancer cells are dying, and that's driving up the PSA. And I don't understand the biology of it, but maybe that's the case. And then, a couple of weeks later, sure enough, the PSA dropped dramatically. Maybe it's indication that the dead cancer cells were driving up the PSA. I don't know.
So at least with Keytruda and who knows, maybe other drugs, we should not give up just because we have an increase in PSA, but wait and see what happens.
Right. We're patients in both senses of the word. We need to.
Yeah.
Yeah, and John, it's not unusual with chemo. It's not unusual with Pluvicto. It's not unusual with a lot of treatments where we'll see a rise before we see a fall. For the very reason that Peter stated, because cells die off. When the cells die off, they generate PSA, and so we see a movement up before we see a movement down. Not unusual.
Yeah.
I have a question for you, Dr. John, which is really right in your wheelhouse. But this anxiety that Peter raises, especially around what could possibly be a psychosomatic complaint, because you're wondering, you feel a pain here, a pain there. Is this the cancer? Is that the cancer? What professional advice? Because you're allowed to give professional advice. What professional advice can you give to this collection of gents who I feel probably are all experiencing either now or have or will what Peter's going through right now?
When Peter was talking, I was trying to sort out in my mind. Peter was telling us that he starts worrying about things, and uh, almost as if the anxiety was uh, just his brain getting carried away with him. But I was also thinking about side effects of the drug. There's plenty of drugs that can make us really anxious, and we can't tell that it's the drug doing it. Um, I mean, look at caffeine, and there's lots of drugs, asthma drugs, and many others that stimulate the brain so that we feel anxious and we think it's our own thinking process, but it's actually a side effect. So in this case, uh, since we're forging ahead with the drug, um, it's not something we can make disappear simply by stopping the drug and seeing what happens to the anxiety. But just because it's a side effect of a drug doesn't mean it can't be calmed down by any of the many, many ways of reducing anxiety. Some of
Mhm.
those ways of reducing anxiety are behavioral and cognitive. We talked about a lot of that in Speaking Freely group recently. So anybody can we can learn from each other, or we can just ask our doctors, or learn from the internet all the various ways of inducing a relaxed state in ourselves.
Mhm.
And then, of course, if that doesn't work, there's plenty of medications, and there's also psychotherapy. And just because it's a side effect of a drug doesn't necessarily mean that those uh, behavioral, cognitive, psychotherapy, and medication methods won't help. So try them all. Learn from. We got to learn from each other what has worked for us for anxiety. Come to Speaking Freely group and learn about a few of those things, and talk to your doctors about medications. They're not dangerous drugs. You don't have to be scared of taking anxiety reducing medications. But of course, it's always best to get away with behavioral and cognitive methods first.
Thank you so much, Dr. John. Any questions on this anxiety issue before we move on?
Well, it looks like in the survey that Herb was talking about, um, I think it was somewhere in the high teens of us had substantial anxiety problems. So don't.
Actually, in the active surveillance group, it was like 57%.
Oh, 57%. Oh, I must be thinking of the depression group then.
Right. The
They were like
depression is
7% or so.
exactly.
Okay. So anxiety is the norm. I
It's
mean,
up there.
we're all sitting here feeling like there's a gun pointed at our head. Of course we're going to be anxious.
And let me just say, guys, that which makes this even more, which makes the point even more strongly, that this survey we sent out was only to active surveillance men. That's why some of you are saying, well, I never got the survey. We didn't. We have not surveyed all of our men on anxiety. Now, most of you sitting in this group are going to say, geez, if I was on active surveillance, so, I'd be so happy. But this is, by the way, this is early low risk active surveillance. This isn't active surveillance after treatment, but it is a significant issue even for those men. And this is why, and I've learned to appreciate that largely through Howard Walensky's work. And that's why we carry this standard for all prostate cancer men, because we recognize that anxiety is huge. If it's 57% in the active surveillance group, I hate to think what it is in this group. Although, you get people like Peter who over the years come to deal with it much, much better. And then there's an incident or something happens, or it's a new drug and it raises its head again. But it'll go. Peter will be in control of this in a month from now. I'm convinced. I'm convinced. Anyway, look, well, we could talk about this mental health issue for the next 2 hours, but we got to move on. So, given that we're talking about anxiety, I think we have to go to another moderator right now, because I also don't want to lose him, because he may drop off before the end. So, Professor Herb, we're putting you up next.
Okay. I've been having real problems with pain. I was having mobility issues for a while after a trip to Paris, and I couldn't walk well. But over the last few weeks, it just got to the point where I just couldn't stand for more than 3 minutes and without intense pain. And I have to lie on my side and then it would go away. And it's very bizarre because if I do lie on my side, it does go away after like 2 minutes. So it seems like it wasn't related to cancer. But my oncologist insisted that it could be related because they found cancer in my hips, which is where the pain is. So today I had radiation. I had proton therapy directed at the hip metastases. And the doc, Sean Collins, said, well, in a week we'll know if it does any effect. But I'm still in pain tonight. And, the other part of it is in dealing with the pain, I try to keep drugs to a minimum, but then I had to escalate to oxycodone in consultation with Dr. John. And yeah, I didn't think I'd become an addict, but I couldn't stand the side effects. It just really is too much for me. So I really don't want to go back to opiates. So that's where I am right now. I'm very anxious about being able to walk again, being able to enjoy. I'm basically a recluse. I can stay home. I can lie down in bed. I'm having trouble sitting in front of the computer. I'm sitting on a soft couch now, but it still hurts. And I just don't know where this is all going. And the Pluvicto's working, so the PSA is down in the 1 range. So that's good. But then there's all this other stuff now that I'm dealing with, and it's making me very anxious. So I'd love feedback about anybody who had, other than from Jimmy, who I talked about. We don't need to talk to Jimmy about opiates, but anybody who had them short term or something. And I talked to John, but I really don't like it. Has anybody gone through it and positively?
And have you tried to leave at all?
Yes, it doesn't do a damn thing.
How much were you taking?
Like 1,000 or something.
Okay, because I had a bad shoulder. I used to shoot a lot of bow, and I had a bad shoulder, and I couldn't. And I was at the orthopod, and he said, "You taking a leave?" I go, "Yeah." Because how many? I go, 2. He goes, "No, no, no." He said, 5 a day is therapeutic, not
Well,
2.
I take 2 at a time, but it didn't do
Okay,
a damn thing.
okay, okay.
Meloxicam didn't do a damn thing. I'm taking mostly 800 milligrams of ibuprofen and
Throw some,
1,000 of acetaminophen.
throw some. Yeah, I was gonna say throw Tylenol. That's the 2 I would suggest. But yeah.
Herb, what are the
Really,
side effects of the opiates that you're not tolerating well?
GI,
Sorry?
GI side effects,
GI. Oh, you mean
gastrointestinal,
constipation.
terrible constipation, terrible stomach pains, regurgitation. It was terrible. I felt
Oh,
like my whole system was full up and I just didn't want to eat anything.
Herb, this is Alan. You mentioned ibuprofen that you're taking. You said 800. Is
Yes.
that 800 several times a day? Well, that's
Yes, of
total
course. Yes.
several times, and it did
Yes.
nothing. Right.
Well,
Okay.
it's not doing nothing. I can't say it's not doing nothing, but it certainly is not giving me pain free. It's not making me pain free.
Right. Okay.
Well, I wonder if the ibuprofen could be causing abdominal pain.
I don't think so, because I've been taking that for a longer time, and it never did. I always take it with food.
I recommend you take Pepsid twice a day, 20
Yeah, well,
milligrams or 40 to protect
I mean,
against that.
I use pantoprazole, which
Okay.
is
Cool.
a
That's fine.
proton pump inhibitor.
Yep. Yep. Good.
Yeah, I'm doing
that
well.
was a good idea, Alan.
Uh, two or three things to say, Herb. One is, um, do you know this thing about like warm water therapy groups, like to do water therapy, the
Yeah.
therapy in the gym, where you can really move around a lot, even though you may be not able to really stand and walk and
Mm-hmm.
get your body. I also tried to send you something a week ago that came back, something that I've done for half my life, something called the Feldenkrais method. I don't know if you ever heard of that.
Mm-hmm.
Uh, I was sending you something. I'll try to send it to you again. I
Oh,
didn't
that would
really
be great.
so severe. And the third thing is that I've been off and on hydrocodone for 10 years, almost 5 years. And that doesn't bother me as much as oxycodone or the Percocet, whatever that
Uh-huh.
is. But I reduce my Advil. I reduce Advil when I add uh, HC hydrocodone. And I take two stool softeners and maybe one Biscopol.
Uh-huh.
If depends. If you take Biscopol too often, you end up with this kind of yucky diarrhea. So, but I usually try to add add very fibrous food and two stool softeners, and
Mm.
drink a lot of liquid to get not to really get that constipation. And I don't really have I have kind of an iron stomach. Maybe I always did kind of spicy food also, actually.
Mm.
So I've gone off and on that. Right now I'm off because I'm about to start radiation and I'm going to be taking it.
Well,
Uh,
that's
So,
interesting. I mean, I will try this. I mean, maybe I have to do it. I mean, it's a matter of the balance. Can I tolerate the pain versus the other side
that,
effects?
I didn't take
And
a
that's
lot,
really,
Herb,
I
what
didn't.
about seeing a pain specialist? I'm sure they know more than anybody
that
how to alleviate side effects.
right. So I'm seeing a pain person on Thursday.
Okay.
so
You
there
have
are a
something?
couple of issues with that maybe the group needs to understand with her. One big issue, which is that it's just not clear if this is cancer related or if it's related to possible deterioration in her spine. Um, and it seems strange that it's cancer related because there's been no huge jump in PSA. There's been no real significant change in metastases. It, it, it doesn't really add up for cancer pain. So that's why, in a sense, this spot RT is diagnostic, because if the pain continues, then it probably is not cancer pain. But this is one of the things we've been wrestling with. How do we figure it out? And Herb's been talking about it with his docs. And the other interesting thing that I wanted to mention is that the radiation that Herb got today was eight, excuse me, 8 grays, all in one session with proton beam. And I am just very curious why Dr. Collins chose to use proton beam as opposed to SBRT, which he has, and we don't know. Herb doesn't know. I don't know. just wondering if anybody has any thoughts on that.
Proton is not as penetrative, but I can't see where they'd pick it because it's not like there's some vital organ right behind the beam,
Right.
that they, so I don't know.
Herb,
Yeah.
is this pain in both hips?
Yes, it's bilateral, and but it mostly, depending on the minute. If I get up in the morning or to pee, it's right hip. But if I'm sitting too much in a position, it's left hip. It's just really weird. But if I lie down, I can get rid of the pain.
I wonder if
I mean, I also thought maybe I should bring in a neurosurgeon
right.
to
I
this team.
That's what I was about to say. I wonder if this could be some sort of a nerve impingement.
Yeah, I mean, that's what I think. But, that's also, I believe me, you can imagine that I've got a great team of doctors,
Right.
and none of them can really nail this.
My idea is that when Herb talks to his pain guy next week, that he considers the possibility of getting the joints injected. You know
Well,
how
that's what they're doing that. That's Thursday.
yeah, I think that how we have so-called theranostics now in cancer treatment, things that are both diagnostic as well as therapeutic, and uh, having the hips injected with steroids and local anesthetic might even be like a theranostic. It might give us an idea whether it's a non-cancer joint pain in the capsule. And you could do that before having to resort to a neurosurgeon.
Right. So there we are, guys. I mean,
Okay.
I stopped going to the gym. I stopped exercising because of the pain. And it's really, that also raises my anxiety because I really, I'm not going to I don't want to end up a recluse.
All right.
Fair enough.
Well, we will continue to support you, rack our brains for the best thing to do. I mean, we're using spot radiation as a diagnostic. We're going to use the injections maybe as a diagnostic. So we'll get to the bottom of it. My money is on a pinched nerve, but we'll see.
Well, thank you, guys.
All right.
We wish you well. We wish you well.
Yeah.
Herb. This disease is so deterioration prone. I mean, we're all going through that. The amount of AT and everything else we put in our bodies. I mean, it's not good, but we do it.
Right.
Okay. Let's go to Mike Yancey.
Okay, I'll try to pull all this together, make it somewhat understandable. But basically, I had a leak come up, and of course, I had 10 rounds of radiation over 10 days, finishing up. I think it was November 10th, and then of course on the 11th, I had my next Pluvicto infusion, and also on the 11th, I switched from Lupron. I started Orgovyx on the 11th. So basically, through the next several days, I had significant fatigue, which I kind of racked up to all the radiation I'd had. But then also in the next couple of days after the 11th, started having headaches. Fatigue was increased, getting worse. Had some nosebleeds, had fever, and I can't remember everything else. But anyway, on the 16th, I had, much like Herb, I had significant hip pain. And so the concern there was cancer, of course. So went in and had a scan done on the 17th, and everything looked good. There was no cancerous lesions, etc. So once I got back home, I was racking my brain. I realized that Orgovyx was the other thing in the mix, if you will. And so I started doing some research. And I've been on a heartburn medicine for about 5 years. My name's Protonix. The generic is penoprozole. And in researching Orgovyx, it talked about you didn't want to mix it with a PGP inhibitor. Well, it just so happened pantoprazole is a PGP inhibitor. And so it does, it basically slows down the metabolism of Orgovyx. And so apparently I was building up Orgovyx in my system. So anyway, had a conversation with the doctor. He said, stop Orgovyx. So I stopped that for 3 days. Actually, I stopped it for 4 days because also then on the 4th day stopped the pantoprazole and started back up with the Orgovyx. So all those things, for the most part, have much resolved themselves then, but just wanted to throw out to the group the fact that sometimes you get some drug interactions that the doctor catch up front. So that's it.
Mike, thanks, Mike. That's very interesting.
Yes.
And it means the pharmacist screwed up. They should
Well, of
have
course,
been able to pick up.
unfortunately, I'm using about 3 different pharmacies.
Right. They should have picked that's it. I mean, I didn't know there was, and by the way, the pronunciation is pantoprazole.
Okay.
But that is a very interesting interaction between pantoprazole and Orgovyx. And Peter had trouble with Orgovyx, right? So maybe Peter, do you take a proton pump inhibitor?
No, but I had a strong reaction to Orgovyx, and I'd never heard of anybody else having one. Yeah, I called up the drug, the National Drug Center and reported it. You might want to do that just so they have a notation of this in case it comes up again or they never heard of it before.
Yeah, because it's not in my interaction checker. I just looked.
Yeah, the FDA.
What kind of response?
FDA has
let all 3 of your pharmacists know about every single drug you're taking. They can't help you if they don't know what you're taking.
Right.
So
I mean, at least
I have a request. If somebody would just put the name of that PGP inhibitor in the chat window, because I will make sure that gets fed back to Myovant this week. I'll let Our Lady at Myovant know, because it's important. It's clearly important. And let me ask you, Mike, how are you resolving this? I mean, have you gone back to a LHRH shot, or have you stopped the heartburn medicine? How are you?
Yeah, at this point, I've stopped the heartburn medicine, so I'm using other things that don't work quite as well, like Melanta and things of that nature. Of course, it's been a long time since I have not used this drug, and what I'm finding, because I've changed my diet pretty significantly due to cancer, the heartburn does not seem to be quite as strong or as irritating as it used to be. I think it's kind of a combination there. It may not be as bad, and so I'm able to kind of manage it with other things like Mylanta.
Okay. All right. Well, that is super helpful, and I'm so glad that you reported it. And we will definitely keep it in mind, and we'll let the right folks know so that other people are aware. And if they want, would you be willing to talk to Myovant if they wanted to talk to you directly?
Absolutely, be more than glad to.
Okay, fine. Thank you so much. Thank you. Okay, anybody else have anything on that one that they want to contribute?
Yeah, now that I see it spelled out, I've been on this for quite a few years.
Well, yeah,
40 milligrams. So, and I was on it when I had the drug reaction to Orgovyx 2 years ago. So, could well be.
And Peter, and I just looked at their drug interactions page, and they have an interaction with famotidine, which is a different proton pump inhibitor. So it may be that this is more universal.
Oh, Herb, famotidine is an H2 antagonist. It's not a PPI.
Well, okay, sorry, right. But it's still a stomach drug, right? You're right. Sorry, Rick. Sorry. Yeah.
Boy, am I glad that you're on this call, Len. Somebody's got to keep that Geller straight, you know. He would have gotten away. He would have gotten away with it. He would have
Got to
gotten
keep
away
me
with
honest.
it.
You got to keep
Who
me honest.
knew? Who knew?
I know Len's not gonna be happy with me, but all that stuff's poison, you guys. You're not supposed to get the acid out of your stomach. You can't do hardly, you don't digest stuff. Your minerals you're short. Take glutamine, DGL, licorice, slippery elm, all that stuff. Much easier on your stomach than
Norm,
that
Norm,
stuff.
I'm going to guess that you've never had GERD or
No,
serious
I
heart.
did have it. I
You
did,
did?
and you know what? And you know what got rid of mine? I quit
What?
wheat. Yeah, no,
What?
I've had it. I've had it bad. And I didn't. I read up on that stuff, and I just won't take it. I just try.
How did you get
All
rid
you
of
guys,
it?
anybody with the first thing you ought to do is just quit bread for a week. You'd be surprised how many people quit bread for a week, and it's just
Well, yeah,
that's just
you're
my
right.
opinion.
Bread
But
can
Yeah,
still,
cause,
you
but
can do it right.
it,
It's amazing how
you're
many
gonna
times.
you're gonna get me and Len and Herb all ganged up on you if you diss all the whole.
I'll go. Yeah,
I know you're happy to take us on, but there are some people
Yeah.
that should not stop
I'm
those
talking from
drugs.
I had a lot of GERD, and once milk, I had my thyroid, and one of the things with thyroid, you get allergic to milk. So I went through that with milk, and then I went through it with bread. I went on Atkins and my stomach doesn't hurt anymore. Quit Atkins, went back to bread, and went, oh crap. So, but yeah,
Anyway,
it's an opinion. Yeah,
let me jump in here because we got to keep this moving. There's a question from
sure.
Joe Gallo that says, "Is this in the same family as Prilosec?" Anybody know that?
yeah, Prilosec is a PPI, proton
Yes.
pump inhibitor.
Yes, Mr. Gallo, Captain
Yes.
Gallo. Yes, it is in the same family. So, and well, you're not taking Orgovyx anymore. Maybe that's what made you so daffy when you were on the Orgovyx.
Could have been.
Yeah. So let me just ask you guys again. I mean, does the Orgovyx insert call out this PPI or in
No.
contraindication?
No.
It does not.
I doubt it. It's not
No.
on my interaction
At the
list at all.
moment, it's not listed on their drug interactions page. They list 329 potential drugs. It's not one of them.
Okay. All
But
right.
if you go to,
Wow.
but one thing but there is something on their drug. If you search for the drug interactions page, there's a QR code on the page that allows you to report this. So I think it would be good, Mike, if you went in and used that QR code
Now
and reported it.
I'll take care of it tomorrow. Okay. I'll take care of it tomorrow, and then we'll get back to if Myavamp wants it done by the patient, we'll let Mike know. We'll let Peter know, because it's not too late for Peter to report it. And
I reported it. I did report it to Myovant, and I also reported it on the FDA number. I talked to the FDA people and reported it in.
okay, we're moving on. We gotta keep moving. We're getting good stuff out here today. So, Anna Moskowitz, what's on your mind?
Ellen, he called on you, Ellen Moskowitz.
Alan, you're muted.
I missed it. My Google speaker was firing off its mouth for some reason. Okay, here's the question I have. Not so much related to me, but most of you have maybe dealt with this situation. I have a friend who just developed recurrent prostate cancer. And as much as I've told him about the group, given him resources, he is sort of doing his own thing. I'm curious to know what the latest thinking is when to start radiation when you have recurrent prostate cancer. Now, things have changed since I had radiation 6 years ago. In his situation, he has a Gleason 4+3. He had
Okay,
surgery
well,
6 months ago.
I'm gonna cut off. We do not. This is just a policy. We won't talk about other people. If they want to
Okay,
come into the group, that's fine. What I'm
that's fine.
happy to discuss. We won't take details, but let's talk about what is the latest thinking on when to start.
So let me
Uh,
picture. Let me put it. I understand, and I thought that might be an issue. Let me put it this way: if you have a PSMA scan that shows nothing, would that impact your decision on when to start radiation? That came up a couple of weeks ago with an older gentleman. He kept watching this PSA going up and up and up, but they hadn't found anything with multiple PSMA tests. Is that sort of the thinking, or is the thinking, you got nothing, but still you should act quickly before the cancer spreads? Let's put it that way, because it's general. I mean, when I had this, you didn't have the luxury of PSMA. I had an MRI, and the thinking was back 6 years ago. If you hit 0.03, 0.1, and got up to 0.2, hey, you better get going if you have a trend, and certainly by 0.2 and in the far out, maybe 0.5. But once you hit that level, your likelihood of a cure was dropping off. Does that change now that you have PSMA? That's the question. Very simple. Maybe not a simple answer.
I'm
who
not
wants
aware
to?
of anyone using PSMA to determine when to do salvage radiation.
What was that?
I am not aware of oncologists using PSMA as a tracking method for when to do salvage radiation. As far as I know, they still use PSA.
Yeah, this was
Anybody?
I don't, he hasn't
Well,
gone to an oncologist yet. He's with a
so
radiology oncologist, a urologist.
so Len, that's not totally right in the sense that if there's recurrence, and Tony Fig is on, so he can talk. He can talk to this. If there's recurrence, then they are going to run a PSMA scan to see if they can see any cancer anywhere.
Yep.
And Tony, come on, join us with your sound and your video if you can. I mean, I know that your Dr. Van V in Rochester, he didn't want to wait. He didn't want to hang around. He wanted to get you to get a PSMA scan under 0.5, and we didn't see anything. So, and you're still less than 6 months out from your surgery. So, I mean, what's your answer to Alan Moskowitz? Because you're in that boat.
Well, that was my question I was going to raise tonight. I did have a trend of the rising PSA, and I had started Firmagon, which brought the testosterone level down as well as the PSA. And I was wondering how long would I stay on just hormone therapy without starting radiation. But Dr. Van felt it was important to get it immediately, so rather than let it progress. So I am scheduled to begin after I've had 6 months out from radical prostatectomy to begin doing the radiation.
And Tony, you
Yeah,
had a PSMA scan already?
Yes,
And you
yes, and it
found
did not
nothing?
detect anything.
yeah.
How
Dr.
high
Gaines,
was the, I'm
Dr.
sorry, how
Gaines
high was your PSA when you had the scan?
0.47, 0.47.
Yeah.
So Dr. Gainesman, he decided with me he was going to do he was going to start the radiation and the hormone treatment. He did a PSMA, but that was just to see if he saw something. He still was going to attack the cancer because he said it's an aggressive cancer. I'm doing it. If the PSMA shows up on something, maybe we can go after, I guess, something specific. But now we're going to start with both. We're going after this full bore.
Yeah, same for me, Dr. E. I'm at 0.2. She said she wants to start at about 0, the radiation and the ADT about 0.2 and not past 0.5. So I start my radiation probably next week.
And Norm, you also had PSMA scan?
Yep, I had the PSMA scan at 0.2 and it didn't show anything. And I asked him, we talked about it, and he said, I just want to make sure that there's not one little hot spot somewhere. And there wasn't. So
I find it very interesting that everybody here is the same sort of thinking, or at least their doctors do. Because, if I was redoing this or I had this condition today, I'd be very reluctant to do anything except active surveillance. Because for all you know, your cancer lesion could not be in the prostate bed. It could be somewhere outside that. And, you've gotten a whole lot of radiation for perhaps zero benefit. And so I sort of, I think of that logically, yet nobody's doctor is doing it. And I don't know whether that's just they want to be super conservative, which is fine. But the risk is you do radiation and you accomplish nothing except give yourself potential side effects down the road. So I think
Alan,
the other side of that coin is you don't do anything and it mets. So who knows?
Yeah,
I can give you
waiting. Hey, come on, can't we wait and let that PSA go up? And boy, she had a physical reaction. And no, we can't do that. And I had a Gleason of 4+4, so I think that also influenced their decision making.
Yeah, probably so. I agree. Aggressiveness makes a big difference.
Hold on a second, Alan. Jerry Pelfrey, go ahead, please.
I can give you an example of it this year. I'll be coming up on my 4th year with Gleason 9. You remember when I started out, my first PSA was 3,193. So within these 4 years, I was getting it down to about 0.16 to 0.2, and all of a sudden it kept going up to 0.27, and my local oncologist, Dr. Bajan, said, you need a PSMA test. And I said, well, it's not 0.5. And he says, well, you still need it. So we did it. We found a nice real hot spot on L4. So I talked to my RO, my radiology oncologist at Mayo, and he was all for going for it. It was about maybe a 0.5 millimeter, but it showed up bright red on the PSMA. So we did radiation salvage treatment, and after that, I got home later. I took my PSA, and it's 0.04.
Great.
But Jerry, this is a different situation. I mean, this is using PSMA for follow, which is good. Although I still think that for most people, you're not going to see a response at the level that you got a response. Some people will, but not everybody. So then there's the question as to how often is your insurance going to pay for a PSMA scan. So you can do it, but as you've heard, you got a response, but Alan didn't get a response, and I forget, A couple of guys, Norm they didn't see anything on Norm, but you do it. Now, the other side of this coin is the research that came out a while back that said in following up an RP, a radical prostatectomy, and following up surgery, it doesn't make a difference whether you follow up with radiation after 3 months or you wait till around 8 months or 9 months. And that was significant. That was a significant paper when it came out. And everybody said, oh, well, we don't need to dive in right away. We'll just let it run up. My own feeling, if it were me, is if in fact it makes no difference between jumping in within 3 months and waiting for the 8 months, I would prefer to wait for the 8 months, because then if the PSMA scan sees specific lesions, they can be targeted when you go in for the salvage radiation, which of course is not targeting particular lesions in bone, it's across the whole pelvic region.
So it seems like, to sum up, the answer to Alan's question is that PSA is still the main biomarker for determining when to start radiation, but PSMA scans might help that radiation to be targeted and aimed properly.
Yeah, I think that's well said. Thank you.
I like that. And I think that our advice might be with this friend of yours, certainly to get himself away from the urologist, whether he just wants to rely on the radiation oncologist right now or he wants to add a GU medical oncologist, I don't know. But I think he probably needs to get himself away from the urologist in making his decisions. It's real interesting, and I'm pretty sure that Dr. E is going to be with us in about 2 weeks, and so one of the things we can ask her is her attitude about jumping in right away or waiting. So there'll be plenty of time to ask questions. So somebody who has that question on their mind, don't rely on me to remember it. Somebody who has that question on their mind, you can ask her when she's in the group with us, and she'll be happy to give you her opinion. I don't think I want to take her on, by the way. Okay, can we keep moving along? I'm keeping one eye on the clock here. Alan C. In New Jersey, what's on your mind?
Yeah, I had a PSMA back in July. It showed a hotspot in the apex. This is following, I had radiation back in 2019. I had a consult with a Fox Chase urologist. He's recommending cryoablation as the salvage or brachy. And the question I had is, he's telling me that the cryoablation complication rate is only 10%. From what I've read, I thought it was much higher, like 50% and upwards. Has anyone in the group have any experience with cryoablation after radiation?
Anybody been offered cryoablation?
No. And then the second choice he said was brachy, which he would not do, but Fox Chase radiation people could do that.
Alan,
he said that I'm sorry,
go ahead.
Yeah, well, he said that he doesn't recommend brachy because I've already had radiation, and he just adds more radiation. So he felt that cryoablation is a better solution, and he also will be the one doing it. So I'm not sure if that's a sales pitch, because 10%, from what I understand, is hard to believe. From what I read, it's much higher.
Are you a guy with a high? I was just wondering if I was wondering if Alan was a guy with a very high Gleason score or a nice low Gleason score?
I had a
Because
4+9, 4+5, 9.
4+5.
Yeah, and then I had radiation.
Usually, that's why none of us know about cryoablation, because guys with high Gleason scores like us don't usually get offered uh, focal treatments, right?
Well,
Yeah,
the
but
reasoning is that the PSMA didn't show anything outside of the prostate. So he said
Yeah.
that's good. Now the problem is my PSA has been rising from non-detectable to the most recent one is 1.2, doubling time is about 7 months. So he said that he would prefer doubling time over a year. If it doubles from here on, say 3 months, that would be a sign to do some kind of treatment. But he would want a biopsy first because he says there's too many false positives with the PSMA. This hotspot could be a radiation artifact. So
well,
he would want a
there's
biopsy before he does anything, any kind of
okay.
treatment.
So there's a couple of issues there. First of all, there's a high rate of false positives with the Pylarify scan with the 18F DCF There is not with the gallium 68. What type of PSMA scan did you get?
The Pylarify.
So maybe you need to get a gallium scan
I
because
did ask him. Did ask him. He said that any.
the gallium scan is more reliable. Secondly, and it shouldn't be an issue at Fox Chase, question of you need to find out who read the scan and what the experience was of the doc that read the scan, how many times they'd read the scan. I mean, if you've got a guy that read that scan and he's only read 2 or 3 scans before, even if he's well trained, that's a concern. So you're entitled to know how many scans were read. And this is an issue. It's an issue we're in discussion with Lantheus right now. And we're trying to obtain some experience badging. But you, Alan, should know that. The third thing is, was that the first PSMA scan you ever had, or had you had one before?
Yes, that's the first one.
Okay.
And it
How
was
do
it
we?
was read it was read locally by the local radiologist. I did have
Okay.
it read again by Massachusetts General, supposedly expert radiologist up there, and he did confirm he did see a lesion in that area of the prostate, as well as we
Okay.
also did an MRI, and he also said it shows up on the MRI, which the local doctor couldn't see on the MRI.
Okay. So which doc is telling you that he's worried about false positives then?
The urologist at Fox Chase. He's saying that, I asked him, should I do a repeat scan or a different scan? He says, it doesn't matter.
I'm confused. If you're fairly convinced that you've had it well read and it's shown up in 2 different places, why is this urologist at Fox Chase?
No, it's showing up the same place in the apex.
Right, but why is he saying that it could be a false positive?
I don't know. That's what he's telling me. He's saying that's why he wants a biopsy.
And let me ask you another question, Alan. Why are you dealing with a urologist?
Because it's from what I was told, it's within the prostate. So the only time I would see a medical oncologist if I'm going to consider hormone therapy.
Well, there are other things too, but I mean, I think that you might need more expertise. And the third thing is, have you had an Axiom scan?
No, that was I asked him about that too. That was recommended. He said, again, by the end of the day, he would not do anything unless he does a biopsy.
And is there a reason why he wouldn't do a biopsy right now?
Oh, he said because my PSA is still low, 1.2. He's using the astral definition of 2 points above nadir. My nadir was non-detectable. So he says I still have time. He says when the PSA approaches 2, then we can do the biopsy. And the biopsy confirms it is cancer and not anything else. Then he would recommend the cryoablation to treat it locally.
What your original treatment was IMRT?
That's correct.
Okay. I think Captain Joe's dog is chasing him around the room there.
Yeah, I've been trying to just jump in real quick and then get out while the dog's talking.
Go ahead, Captain Joe.
The nuclear med guy at Fox Chase is Dr. Yu, YU, and he is experienced at reading PSMA scans. In fact, he's the one who set up their program there. So see if you can get the information off to him.
I did send the images to the doctor and asked him if he can forward it to his experts. He said it doesn't matter. He said he wouldn't do anything unless he does a biopsy, regardless of
Who's your urologist there?
David Chen.
Okay. I'd still ask him to forward it to the nuclear medicine doctor. He goes by Michael Yu, but his name.
I realize that because that's why I sent Chen the images. But he said
But just
no, it
tell
wasn't
him to be a little bit more persistent about it. He actually came to one of our support groups, and he is very approachable. Okay.
But I see Chen's point. He says even if I do another scan, what will it tell us if it confirms that there's a hot spot? He still says he needs to go in and do a biopsy so he can identify the areas to focus the cryotherapy on.
Look, here's my concern. You're a 4+5, and your disease has come back, right?
Yes.
Now, it's possible that what's causing it is that spot in the prostate, but it's pretty unusual because you had how many sessions of IMRT did you have originally?
I forget. It was like 20 something, 81 gray total.
Okay.
26, I believe.
And they never and with a 4 plus
40,
5,
46, 46, 26.
46.
Yeah.
And did they radiate your whole pelvic girdle?
Yes, the lymph nodes and the prostate gland.
Okay. So my concern is this. It's pretty unusual, and this is why I think I would be speaking to a medical oncologist. It's kind of unusual that you would have something come up within the gland. We don't hear that much, that really? Often. Not that it couldn't happen, but we don't hear it. So it's a weird situation, and you don't want to wait around if in fact there's something going on that's outside the gland. And that's the concern. Your urologist is gland focused because he's a urologist. But it may not be only in the gland. And you're entitled to have more opinions, especially at a hospital like Fox Chase, and find out from somebody else. Do they think you're a 4+5? It could have gone out the gland. There could be micrometastasis somewhere else. It could well be that you need to start hormone therapy or you need to do something else. If it was me, that's what I would do. I'm not sure with a 4+5 and a current PSA of 1.2.
1.2, yeah.
I would be hanging around and waiting for it to go up. It's easy for Dr. Chen to say that, but it ain't him. Mm-hmm. And he's not thinking about the fact that it could be beyond there, and that's my criticism of Chen.
Yeah, I did ask him about that possibility. He says that's why we need the biopsy. If the biopsy comes back negative.
But he doesn't want to do the biopsy. He says let's wait on the biopsy.
Well, he's saying wait till 2. I don't know. The Astro guy.
What are we waiting for?
I don't know.
Well, are we waiting for the disease to get worse? Alan, you've got to advocate for yourself. You've got to be your own best advocate here. And being your own best advocate means, I'll come to you in a sec, Joe. Being your own best advocate means that you need more than an opinion from this urologist. And maybe a place to start is talking to some other people at Fox Chase. Our Fox Chase expert is Joe Gallo. So Joe, what's on your mind?
I would give an appointment with Dan Geinesman.
Yeah, I would too.
He is excellent. He follows up and he's well coordinated. And then he will talk with Eric Horowitz, who is the head of radiology, as well as the other guys. Uh, I personally, I love the urologist there, but I would not be hanging my hat with them at this point.
Yeah,
Which
Yeah, I would go
urologist did you deal with at Fox Chase?
Korea, the one I dealt
Or
with. Yeah,
okay.
but
and I,
I've moved on from Korea. I deal with gynesmen now regularly. In fact, I see him in a couple of weeks, and I'm a 4+5 as well. And the other thing is that Horowitz, who's the head there, can also talk to you about the possibility of using brachy. Okay,
yeah,
that's their experience with that.
I'll tell you, Alan, it was so easy. I couldn't believe it. I know Rick and Joe recommended I see Gainesman, and I thought, oh man, I don't know, changing doctors. I just called up, made the appointment. They said, fine, we'll cancel the other and put you with, Gainesman, and he was great. So it was really
Well,
easy to get an appointment with him.
I did try to make an appointment with Geinsman a few months back, but his office told me that he would not do a telehealth. I would have to drive in person, drive a couple of hours to Philadelphia. But Chen's office was more than eager to do the telehealth. So I'm not sure why Geinsman.
For Alan,
Yeah.
this is your life, man.
Yeah.
No.
Drive
I intend to follow up with
drive
Geinsman shortly
to
if I can get an
Fox
appointment.
Chase and get an appointment with Gainesman. What are you going to tell us when the disease is everywhere? Oh, well, we might have caught it if I'd taken a 2-hour drive to Gainesman.
And I do get telehealth from Gainesman. I drove down there an hour and 3/4 the first time, and it was worth every minute of the drive. And then after that, we were able to do telehealth. So he does some telehealth.
He's
Well,
very open. He'll do a telehealth. He'll do email. He's well, like you're just hearing. He's extremely approachable. He can coordinate. He talks well with the radonks over there, which Horowitz is the chief guy. But he's got a couple of guys on there who can talk to you about brachy if that is a possibility. I would not leave it as good as the oncologists are, the urologists rather. I would not leave it to them to be my sole guide. Not with a 4+5, and I'm a 4+5.
Agreed. That's why I
And
was
not with a
reaching out.
visible lesion. Not with a visible lesion. I mean, what are you waiting for?
Yeah.
It's there. It's just going to get bigger.
Yeah.
Well, do you guys recommend I go ahead with the biopsy?
No, I think what we recommend is you go talk to Dan Gainesman and see whether he thinks you should get a biopsy and what he thinks you should do. I think that's what we would say. We wouldn't recommend one way or the other. I can only tell you what I would do in your situation. And my first step would be to go talk to Gainesman and say, what do you think, Doc? Do you think I should get the biopsy? Do you think I should wait till it gets to 2? Should I jump in right now? Do I need to get onto hormone therapy? Those are the questions I'd be asking Dan Gainesman.
And he has command of all the things that you talked about, including working with Dr. Yu on the PSMA PET. So I mean, it's like he's the perfect quarterback, and he is the head of the GU Medoncs.
Okay. I
And
plan
he
to,
knows AnCan.
Yeah, I
He
plan
sure
to
does.
meet to schedule an appointment with him after my next PSA, which is tomorrow. So we'll see what that number comes up.
I'm sorry, what? Say that again?
I have a PSA tomorrow, lab test PSA tomorrow. I
Okay.
want to see what that number is, and then I'll see if I can get a consult with him shortly thereafter.
Okay.
Good luck.
All right,
Alan.
we're gonna keep moving. We're gonna keep moving. Alan C. We're gonna go to Dennis McGuire, who's got an update for us. What's going on there?
Hey everyone. So it's been 4 months since my last Pluvicto treatment. My PSA is increased to 40, and my blood counts have not recovered yet. So I had blood tests 2 weeks ago. So my reds, my whites, my hemoglobin and my platelets right now are really too low to have any more Pluvicto treatments or to consider chemo at this point. So while I'm waiting for my blood counts to recover, I'm going to pursue a clinical trial with my doctor at the University of Wisconsin. This trial is it's kind of a next generation anti-androgen drug. It's a androgen receptor degrader, and the company that is sponsoring it is Arvinas. It is moving to Part B of a phase 1 trial. The Part A of the phase 1 had good results. Patients did get a good PSA response. And right now it's currently active at 6 clinics across the US. So that's the update.
Is this the ARV 110 or is this a different one?
Yeah, it's the next generation of 110. It's ARV 766.
Okay.
It's been reformulated. I think 110 is going to a phase 3 trial, but it seems to only work on a couple of mutations. And the goal with 766 is to have it work on more cancer, including wild type.
Okay. Any questions, thoughts, brains trust, anything you want to say on these androgen receptor degraders?
Well, I've heard that term tossed around for years. Hopefully this one will be different, but in the past, they really haven't been proven to be degrading the AR receptor, or at least they haven't been effective. But, it's the next generation. Dennis, what I'm more interested in, though, is since this is only a phase 1B, what happens, is usually a very quick trial. What happens after your participation in the trial is over? Will they continue to give you the drug if it's working?
Yes, I did ask
good.
that question. Yeah, so if it does work, I would continue on drug.
Okay.
And how quickly do they tell you they think they would see a response from their experience if it is working?
Oh, I think 40 to 50% they see a response within the first 3 to 4 weeks.
Okay. The question that I have is, what can we do to get your blood counts to recover?
Yeah, I just think it's time. I've had those questions. Is there anything with diet, exercise, supplements? Doesn't seem to be anything I'm aware of. I think the Pluvicto, unfortunately, just did some damage to the bone marrow, and it's just taking time for it to recover.
Are your iron levels normal?
Iron levels are fine. Yeah. My hemoglobin now is 9.6, and for reference, before I started Pluvicto, it was 14.
Right.
That's a big drop.
Yeah.
Did you ever have Procrit, Dennis?
No, I haven't.
And what was your platelet count?
My platelets are 105.
That's not too bad.
Yeah, that's not bad.
Yeah, and before I started, they were 160.
Well, I mean, you know, Procrit I know is very controversial, but it might be worth a discussion about Procrit.
Yeah.
You know, I
Yeah,
mean, when I
Depends.
go ahead, Dr. John.
Oh, sorry, I didn't mean to talk over. I, I was thinking it kind of depends on the mechanism of how the drug is accomplishing that. In other words, is it acting at the level of the bone marrow and preventing cells from being uh, manufactured, or is it actually acting at the level of the bloodstream? And this is hemolysis, actually destruction of red blood cells. Does anyone know? Because that would sort of lead us to whether Procrit might work or not, or whether it's simply a matter of getting a transfusion when it's too low, right?
I mean, I guess that's a question that goes to the radionuclide impact on the bone marrow from the theranostic, John. I don't know. That's way above my pay grade. I mean,
That's how that's how radiation usually works, right? At the level of does its harm at the level of the bone marrow.
so if that were the case, would Procrit
Right.
work or would Procrit not work if it was doing damage at the level of the bone marrow?
I would think it would help.
Yeah, it would, because Procrit is basically a mimic of a natural hormone in the body that stimulates red blood cell production in the bone marrow.
And isn't the argument against Procrit that you can have a graft versus host response to it? Some people have a graft versus host response to it.
I haven't heard that. The only concern I heard was, and this was years ago, and I think they've kind of dismissed it at this point, is that it could promote tumor growth because it's kind of anabolic. But I think they've kind of haven't seen enough evidence of that to still maintain that that's an issue. I think is Peter still with us?
No, he had to leave because he did
Oh,
get it.
yeah,
Has
because
anyone else on the call gotten Procrit?
Here's a statement. In clinical studies, this class of drugs shortened overall survival or increased risk of tumor progression in patients with breast, head and neck cancers, lymphoid non-small cell lung cancers, and cervical cancers. That must be what Len was talking about.
yeah. Well, when was that published, John?
Yeah.
I'm just reading Medscape,
Oh, okay.
so I don't have a publication on that. There's a special program, it says, when you prescribe this drug to cancer patients. It's called the ESA Apprise Oncology Program. So I guess they keep close watch on you.
Yeah.
You know, I think, Dennis, if it were me, I would try and push for the Procrit before I went into the trial and see if you get a response from it. And if it seems to help you and recover your numbers, then maybe you don't need to do the trial.
Yep.
I mean, it's sort of, you're exposing yourself again in a 1B trial to a drug we don't know a lot about, and you're not in a great situation um, with your blood counts right now. So let's focus on those blood counts and then go back to something that we know is tried and tested, and we may be able to get your blood counts to recover. And I know these docs want to put people into trials, but this is where the conflict of interest exists in centers of excellence.
Right. So the other thing would be the platelet counts at just over 100. Is that
It's okay
um,
so far.
yeah? When does it get to a danger point?
Oh, what do you think, Len? 50? I mean,
Well,
I've had.
I mean, in a hospital, if you were in a hospital, they wouldn't give you a platelet infusion unless your platelets were below 40.
Yeah.
Yeah.
So, you've got a lot of room there. I don't think that's an issue. I mean, you said before you were 160.
Yeah.
How far back have you tracked it? Have you ever had much higher than that?
No. Early stage of cancer, 7 years ago, I think I was still that in the 160, 150 area.
Yeah, because for me, even before I had cancer, my platelet counts were always, around 140, 150. It was never any better than that. And since then, they fluctuated between about 110 and 125. And I'm not even on anything right now. So, for you, that platelet count may be just a little bit above your normal, a little bit below your normal.
Guys, I've got to keep moving. We've still
Yeah.
got 5 guys to get to.
Yeah.
So,
Okay. Thanks for the
but
input.
I think that you've got some takeaway advice for what it's worth, which is to push to have a discussion with your docs about the Procrit.
Yeah. Okay.
Okay.
Thanks.
So here's who I see that still wants time. Dr. Bob, Frank Fabish, Norm Pollock, and Pat Martin, and Richard Craymond. So I'm going to try and get through to all of you. I haven't forgotten anybody. I've got everything going here. So we'll go down in that order. Dr. Bob.
Okay, thanks. So just an update. I had my 6 weeks post chemo visit with my doctor today. Had my scans last week. Scans showed a few additional Mets compared to 7 months ago, but everything seems to be sclerotic. So my doctor was pretty satisfied with that. But 6 weeks after my last chemo, you were talking about blood counts, my white count, my neutrophils are still low. Not so low that I'm in neutropenic, but for a while I was pretty low. They put me on prophylactic Cipro over Thanksgiving because I was going down to visit family, and but my white count's 2.5, my neutrophils are 1.5. So she wants to see my white counts go up, hopefully soon. And the only other thing is I'm starting abiraterone again tonight or tomorrow, that is, and hopefully that will sit with me. Last time it drove my liver numbers way up right before chemo started. So I was a little nervous going in because of the increased number of Mets, but the fact that everything's turning sclerotic, I guess, is a pretty good sign. And my PSA is down to 0.66, started at over 28. So That's about it.
Are you going to take the Abbey, low dose Abbey with food?
No, I'm going to take 500 milligrams instead of 1,000. Like, when I wake up in the middle of the night to pee, and then in the morning with breakfast have the prednisone. She wants me to stick to half dose for a while to see if that works okay for me and there's no toxicity.
Okay. I mean, I was just thinking about the low dose with food because it might be easier on the liver that way. And it might be
Yeah,
worth discussing that with her.
yeah, but my understanding is low dose with food increases the available amount of Abby, so you end up with kind of the same as if you're taking 1,000 milligrams on an empty stomach. That's my understanding,
Well,
at least.
well, it depends how much you take. You're right. But I'm not necessarily, if maybe you take, instead of taking a quarter dose, you take an eighth dose with food, and then that's easier on your stomach, on your liver, than taking 500, than taking the 500. But it's just a thought.
Yeah, the other thing she talked about was the possibility of, instead of 5 milligrams prednisone, maybe 7.5. So, you know, we'll start it, and I've got, a standing order for blood work, so I'll go, every 5 to 7 days, and we'll see what happens.
Are you going to take the prednisone all in one go, or 2 by 2.5?
I only have 5 milligram tabs, so I'll take it with breakfast,
Okay.
unless somebody thinks it's better to split it up. The only thing taking it later is potentially interfering with sleep.
Right. I don't know.
I think
We've got lots of Abbey people. What did the Abiraterone guys have to say about two
I,
by 2.5 versus 1 by 5?
I think once a day is okay. My 2 cents.
Agree with that.
Okay.
I do once a day.
Okay.
All right,
Okay.
thanks.
Well, good luck. Keep us posted, Dr. Bob, on how you do, and hopefully those white counts are going to come back up pretty quickly.
Yeah, that's my hope. Thanks.
All right. Let me make a note here, Dr. Bob. Abby starting. Okay. Who was next on that list? Frank Fabish.
A quick update. I finished my chemo in April of 2021. I'm now currently on Orgovyx and darolutamide daily pills. I'm on a 3-month checkup with my doc, and my last checkup last week, everything was in line, all of the blood work. The testosterone was 15. My PSA was 0.06. The only little bit of surprise was over the last 3 PSAs, I've gone, and that's over almost 6 months, I've gone from 0.04 to 0.05 to 0.06. My doctor isn't concerned about it. He's just watchful, and he wants to see where it goes the next 3-month appointment. He's satisfied with the way results are, and he said that certainly the little bit of rise in the PSA is within the error margins of the test.
Right. Yeah, I was just going to say that it's well within the error margins. You could have tested any one of those again and gotten a different number, I'd say.
Right. So he was satisfied, I was satisfied, and especially with the fact that he's staying with the 3-month checkup, that was very comforting to me.
Okay.
That's my update. All
And
positive.
and I'm assuming that you don't take any of those PPI drugs, those pump inhibitor, whatever they're called.
No,
You're not on any of those heartburn drugs or anything, right?
no, nope,
Good.
none of those. Just the side effects from the 2 meds.
Okay. Anybody have anything they want to say to Frank? Questions?
Way to go.
Okay.
Right. Keep it up.
Keep it up.
Absolutely.
We love it. We love it. We love it. Okay.
Yep.
All right. Next on my list was Norm Pollock.
I just started my my Orgovyx in Nubeca on the 21st, and by Saturday I started having hot flashes, and they're like a lot of fun, guys. Anybody got any suggestions?
Ember Wave.
Ember Wave.
Yeah, I looked at that, but I thought it's like you got to wake up to hit it.
No,
Just
it
sleeping
has
is
an all
problem,
night.
no?
It has an all night mode.
It has an all-night mode.
It has an all-night mode. It has a sleep mode that you can set that it'll work for 30 minutes to get you to sleep, and it has a hot flash mode that you can use for 3 to 10 minutes, depending upon how you set it.
Might have to look into that. Man, I'm having one now. It's just like that's bad enough. I say they throw salt in the wound because then you get cold right after. So it's like can't make up my
It has
mind.
helped me,
Okay.
and I continue to use it.
Yeah, because sleep's real important. I hate not sleeping. That's tough.
Right.
Well,
So, and
we've had a lot of success with Ember Wave, and
okay.
there is we have a discount. I'll put it in the chat. It's AnCan 50, and I think they take
Okay.
$50 off with that. It should work.
Okay.
Yeah.
I'll order it. I'll order it as soon as we're done.
And
on top of that, you can go to Amazon and get fans, hand fans that you can carry around, or there's a fan that will wrap around your neck. Okay?
Okay.
They work beautifully along with the Ember Wave. I've got the Ember Wave, but on top of that, I use fans.
Okay, I'll try that too. This is true. All the women are going, see? It's like, yeah, no, I don't need to see. Yeah.
now we've got a lot more tricks up our sleeve for hot flashes, believe me. But
Okay.
but start with the Ember Wave. I'll give you one more, Norm, because it is probably right up your street from acupuncture. And
Okay.
the acupuncturists know the points for hot flashes. And
Okay.
it works really well, but it only lasts about 2 to 3 weeks, so you have to go back and get another treatment. But we've seen a lot of good results with acupuncture.
Okay. I'll try that.
All right.
And I got my and Friday I had my first scan for my radiation therapy. So
Okay. And let me ask you, I know we're running late, but how's the wife doing with her DBS?
she gets turned on tomorrow, gets programmed tomorrow, her first program. Little tough. Her honeymoon wore off and she's back to where she was and not doing well. So hopefully this is gonna pick her up a little bit. So but
Hopefully,
she's
yeah.
healing
I mean,
nicely and no infection, which is really a tough one. So
okay.
yeah.
Good.
Thanks for
Good.
asking.
Yeah, good. All right. We've got got Pat Martin and Richard Craymond, and so we're not going to be too late. So Pat Martin, speak to us.
Okay. I started Keytruda several weeks ago. I've had 4 infusions. And since I started it, my PSA has gone from 0.5 to 4.2. And so I'm going to have some more scans done, not this Wednesday, but the following, and see where the action is, and maybe change me to just a straight up chemo, maybe darolutamide or one of the uh, drugs from uh, taxine type drugs. Anyway, other than that, doing okay.
Well, have you huddled with Peter?
No, I haven't.
I
I
think you
haven't.
need to.
Yeah, what he was saying today, it really encouraged me, because I was thinking, man, if that's the case, my PSA is going up because my cancer's dying. I'd anyway like to get together with him.
So, um, his email is peterk@ancan.org.
Okay, good.
And that should be easy for you. And I will email you. I'll email you right now. I'll send it to you directly. I'll send you. Well, one of the other guys. Dr. John, could you send Peter's cell number to direct message it to Peter, to Pat Martin, please?
If I got it, let me check. I'll see if I still got it while you're.
Oh, Len has it.
I'm
Don't
sorry.
worry.
What do you need, Rick?
Would you send Peter Kafka's cell number to Pat Martin, please?
Okay.
Yeah, I don't
I'll
have
put
it.
it. I'll put it. Can I put it in the chat, or is it too late?
No.
Put it in the chat, but directly to him. I put it in the chat directly to Pat Martin.
Okay.
That'd be good.
Thanks. And
Very
his
good. That's all I
email.
had.
Yes, his email. Well, I think it's a lot, because when you're taking this drug, and Peter went from whatever it was, 1 to 7, 1.4 to 7, and he was really concerned about that. So, and then he dropped from 7 back to 1.4.
Good.
So I really think you should. What are your doctors saying about the Keytruda, Pat?
The last time I saw him was the last time I got a shot and an infusion. I'm still getting my Eligard also. So he basically said it doesn't look like it's doing its work, and so we'll take a closer look after you've got your scans, and then possibly change, or I'll bring this up to him also and ask him to consider that. So I'll go from there.
So
He's
Peter's
concerned. He doesn't think, huh?
Peter's in Hawaii, as you know. So right now he's 2 hours behind you. Okay.
Yeah.
And he's real good about getting back to you. So send him an email, give him a call, and discuss it between the two of you. And I can't think of a better person to provide you some support right now.
I can't either. So look forward to seeing him or hearing from him. I'll dial him up here shortly. I'll put it in my phone and get him in the morning.
Okay.
Okay. Thanks much.
And last but certainly not least, Richard Craymond.
Well, mine's going to be real short too.
Good.
I went through the CT scan again, and basically there's some slight improvement in the lymph nodes, and no changes in the nodules in the lungs. They're still there. There's still a lot of them, but that's basically it. The lab work, I don't know if I talked about it before. I haven't. PSA is non-detectable, but that's not useful metric for me. And
Right.
testosterone is too. So it's going along good. Hopefully, I'm not going to go back onto the chemo again that I ended in July. So we'll just keep hanging in there. I don't know what else to say.
And who do you feel is your quarterback, Dr. Apollo, or your guy in your guy up in the young guy, or I
Yeah,
forget
the
it.
young guy, Alan, and Markowski,
Yeah.
Johns Hopkins, and turns out I may have started something. The two of them have started working together on. They told me not only my case, but other cases as well.
That's good. That's good.
So
And so the treatment you're on right now is the hormone therapy and the abiraterone?
yes, so far that isn't. The Abby has kind of got some side effects with joints and things like that, and the neuropathy, and so there's some what is it? Guy Bantra, because gamma penton just knocked me for a loop. I couldn't do anything. I was kind of a zombie.
The gabapentin you're talking about.
Yeah. I should have remembered that because I was on it for neuropathy almost 20 years ago, and then I gave it up just because of the side effects. And this time it didn't work any better. Matter of fact, it was even worse.
Yeah, I mean, I
tried your B6, or I'm trying it.
It didn't. How much are you taking, Richard?
What is it? One tablet, which is what?
Yeah.
I was going to ask you about that.
Take more. You can take a hell of a lot more.
Okay.
So try taking 2 or 3 tablets.
Okay.
And see if it makes a difference.
Yeah. What's that? 1,000 units? I don't have it in front of me.
Yeah, my doc has me taking 100 milligrams 3 times a day for neuropathy. The other thing that actually has helped me, not so much, I've tried it with hot flashes. It hasn't really helped, but acupuncture has helped the neuropathy for me.
I tried that, and that was marginal.
Yeah.
It didn't hurt. There was a little improvement, but not significant.
Yeah, everybody's different. The other thing I read about and I haven't tried is alpha lipoic acid, which is a supplement.
Yes, that's a very good suggestion to add to it. I'm sorry.
Okay.
I'm trying to get. I'm trying to talk to Tom. Tom, don't hang up. I'd like to talk to you. Um, when we're done, I'm happy to talk to you before we finish. Um,
Okay.
so yeah, anybody, the problem is that with this weird prostate cancer that you have, foamy gland prostate cancer,
Yeah.
I don't, I think that nobody really knows what works with it or for
Yeah.
it.
Well,
And go ahead.
this regimen seems to be working. I mean, it's no miracle by any means, but it's reducing the size of the nodules and the lymph nodes. So slowly, but that's better than the other way. And I think we've talked about, well, you were talking about it before, about the Tempest testing, the genomic and those
Yeah,
were all negative. So
yeah, 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 yeah. Um, yeah,
so,
yeah.
so until after the first year, I guess I'll just hang in with this. And that was interesting about splitting up the Abbey, because I've been taking the 4 250 tablets first thing in the morning without any on an empty stomach,
Right.
and
Well,
the
the other
prednisone
way,
at the same time.
yeah, the other way to do it, which, and there have been plenty of trials around it, is to you take a quarter dose with food. Is it a quarter dose, Len, or a half dose? Quarter dose, isn't it?
Quarter, yeah.
You take a quarter dose with food. Some of the GU med oncs are happy with it, others are not. But it seems to work. So,
Okay.
But
but you know
the
what?
problem
If
is
if you
there's no real
go
there's
ahead,
no
Herb.
real data. No, there's unfortunately nobody ever carried it through to a real trial.
Yeah. But if it ain't broke, don't. If it ain't broke, you don't have to fix it. If you're okay with what you're doing right now, stick
As
with it.
long as I'm hanging in there, because anytime that I'm not getting improvement, then I'm going back on chemo. That seems to work.
Well,
So
what about? I mean, do we know if your prostate cancer expresses PSMA?
no, we don't.
Well, I think one of the things I'd be doing is, have you had any PSMA scans?
No.
I think that I'd be talking to Alan or, and the other guy. Let's do a PSMA scan. Let's see. Maybe you'll respond to Pluvicto.
Yeah. Oh, I would. The only issue right now is the PSA is non-detectable.
Yeah. So it's
That's good.
not going to
So I'd
have.
have to back off on what I'm
Yeah.
doing.
Yeah.
Well, I think the discussion with them is can we find out if can we figure out a way to find out if I make PSMA and if I'm a candidate for Pluvicto and see what they say. Gents, any thoughts? No, I guess not.
Well, his PSA is 0.
Yeah, but he has
Yeah.
this foamy gland. He has this foamy gland carcinoma, which is not normal, Herb.
Huh.
That's the wrench in the
Right.
works.
And my PSA was 2 when we started. when I was diagnosed.
with a lot of metastasis.
Yes.
So that's the problem.
So anyway, right now
All right.
it feels good
Okay.
to be improving, not very fast, but improving compared to what I was expecting. And the chemo worked very well.
Okay.
And
We're glad to hear it.
Good
so,
show, Richard.
Yeah, so I could go back on that, and I sailed through that. I only had one short issue with the white blood count suddenly dipped for a couple of days, but out of 18 weeks. So, and my hair hasn't come back, but
It will.
it's coming back very slowly.
It will.
But, that's the least of my problems, I guess.
Yeah. Okay.
Okay.
Well,
Thank
I
you.
think we're going to call it a day. I'm going to hang on and talk to Tom a little bit about GU medical oncologists in the LA region. Anybody's welcome to go, but because I think probably we should stop the recording, which I'm going to do right now.